and a warm welcome to today's edition of Pathcast. Today is October 21st. It's a Tuesday, and I'm Rifat Mannan in California. So we are delighted today to host Professor Laura Tafe, and she's going to give a talk on a very important topic today. And Professor Tafe is a professor of pathology and laboratory medicine, and she is at Dartmouth Hitchcock Medical Center at Geisel School of Medicine at Dartmouth. And today she is going to talk on different oncogenic viruses, as something which we don't discuss much. And she's going to talk on mechanisms, associated cancers, and testing methodologies. And I'm sure this topic would be especially useful for the trainees all over and also the practicing pathologists. And thank you so much, Professor Tafe, for joining us today. Over to you now.
Great, thank you very much. Thank you, everyone. I'm going to go off video to make sure everything runs really well. And so just to get started here. I really like this topic. Oncogenic viruses has been an interest of mine for a long time. And it's a particularly nice bridge, I think, for me, because I practice anatomic pathology as well as molecular diagnostic pathology. And so oncogenic viruses come up quite frequently in both these areas of practice, which I think is really kind of one of the areas that excites me about linking surg path and molecular pathology together. So today, let's talk a little bit about the oncogenic viruses. I have nothing to disclose. So it's believed that up to about 20% of human cancers are thought to be of viral origin or associated with viral infection. Of course, virus infection alone is not always the only factor. There can also be genetic reasons as well as immunologic environmental factors too. But viruses are known to have the capacity to transform cells. Today, we're going to discuss focused on these four main viruses, but we're going to talk about the rest of them as well. We're going to focus in on some of the mechanisms of infection and tumorigenesis, and some of the tests we use in the clinical laboratory to identify these entities. And I want to highlight here that for the most part, a majority of these are preventable cancers, which means that we do have the capacity for vaccination in a number of different viruses, as well as drug therapies that can eliminate viral infections in some instances. And the classification of pathogenic entities or etiologies is put forth by the International Agency for Research on Cancer. And they divide them into these four groups, or with three numbers. And we're going to talk about some of the viruses that fall into this group 1, which are known to be carcinogenic to humans. And just for you to think to yourself for a second, how many group 1 oncogenic viruses are there in humans? So I'll let you get a number in your head. And so a few months ago, I would have answered that there were 7, but now there's officially 9. And that is that in recent months, the carcinogenicity of hepatitis D virus and Merkel cell polyomavirus have upgraded these to group 1 types of viruses. And interestingly, this paper comes from one of our colleagues here at my institution, Dr. Kargas, who is a medical epidemiologist with a lot of focus on infectious etiologies in cancer. So the next question, now that we have nine viruses to talk about, can you name them all? And we will continue to move this along so we can have some time for discussion. So here are the 9 oncogenic viruses. They can be integrative, which means that they do have the capacity to integrate into the host genome, or they can be non-integrative. They are a mixture of DNA and RNA viruses, and you can see them listed here. So the integrative ones, HBV, HPV, the Merkel cell, HTLV, HIV. Non-integrative HCV, EBV, Kaposi sarcoma, and HDV being relatively the new one to be discussed. And overall, the global impact of viral oncogenesis in viral-related tumors remains significant. And so, as you can see, I highlighted North America as well as kind of global populations, but by different viruses, we do see that there continues to be large proportions of cancers that have viral etiologies. And just to bring this home a little bit more, Uganda, who plays an important part of the history of some of the viral oncogenesis discoveries. Uganda, for instance, about 6 of every 10 cancers are caused by infectious agents. And some data from 2018 indicate that among virus-related cancers, about 49% were induced by HPV, 26% were triggered by HBV, 11% by HCV, 11% by EBV, and approximately 3% associated with other related viruses. And so for these viruses to become oncogenic, there are a number of factors that play. Oncogenesis, kind of on a broader front, we think about chronic inflammation, environmental mutagens, immunosuppression, and host genetic background. And for the viruses specifically, they have to have some features in order to have the capacity to become oncogenic. And that is that they have to be transmissible between humans. They have to be able to establish chronic infection, co-opt the cellular processes, undermine immune recognition and surveillance, and derail the conserved cell cycle control pathways. And this model here essentially says that some of these similar mechanisms overall. So again, to think about, they either have oncogenic activation or actual tumor suppression gene inhibition. They induce genomic instability. They can have dysregulation of the cell cycle so that there is increased proliferation, decreased apoptosis. They have immune evasion and chronic inflammation of the surrounding tissues. They can induce angiogenesis even and have extracellular matrix remodeling, which helps to enable neoplastic cells to become invasive. And they can have metabolic reprogramming. So really kind of all the features we think about of kind of the pathogenesis of cancer, all these can have mechanisms related to oncogenicity that is viral induced. And I wanted to share a couple of tables, which I think will probably be high yield for you to look back on about the different viruses themselves, the types of cells that they infect, diseases that they are associated with, and cancers they are associated with. And so this is in the presentation for your reference to go through each of these viruses. And then subsequently, to talk about, just to list here some of the important oncogenes or oncoproteins that are derived from these viruses, have the pathways they tend to target, as well as, again, the cancers that are induced by them. So hopefully you'll find this as a helpful resource down the road when you need to come back and think about all these oncogenic viruses and the differences in terms of DNA, RNA, and some of the importance of the the viral proteins that they induce. So how are cells transformed? So cell cycle control changes due to viral genes are really important. They can interact directly with proteins in the cycle. They can either bind and inhibit them or degrade them. They can interfere with expression of the host cell cycle control genes as well. And they interact with host signaling pathways. And in order to do this, they have to disrupt tumor suppressive genes. They might have oncogenic alkyl-proteins. They can drive the cells into synthesis of the S phase, replication of the virus, and they also can inhibit the p53 regulation, which controls the cell cycle and leads to evasion of apoptosis. And if you're familiar with some of the cellular pathways that we see often in cancers, these are often pathways that we see mutations in terms of oncogenic mutations in cancers that is part of what we test for in the molecular pathology laboratory. And so you will see kind of in the next few slides, a couple of these pathways that are taken advantage of also by these viruses, and disrupt some of the similar cellular pathways that we see mutations actually doing as well in cancers. And so some of the pathways are just outlined in the next several slides. You can see in the little tan to orange boxes, you can see the various viruses and their oncogenic proteins that have different effects at various places in the pathways. These arrows indicate an activating effect, and then the block sign indicates that there is an inhibitory effect. And so, for instance, we hear about the PI3 kinase quite often in a number of cancers. And again, this plays a role in viral oncogenesis. This is a nutrient sensing pathway, and pathway activation becomes activated even when nutrients are low, which leads to increased survival and proliferation of infected cells. The MAP kinase signaling pathway is so important for a number of tumors. And again, we do see that indeed various viruses take advantage of this pathway as well. And this can regulate transcription of genes that control cell cycle proliferation also. The Notch pathway, we see that is a tumor promoting pathway in several of the lymphoid malignancies and breast cancer. This is tumor suppressor pathway also in skin epithelium and pancreatic cells. And excuse me, HPV viruses can repress the Notch pathway, promoting viral persistence in the basal epithelial cells. So again, another mechanism by which the virus persists within human cells. The Wnt beta-catenin pathway is important for cell growth, stem cell renewal, differentiation, and upregulation of CCND1 or cyclin D1 and MYC proteins or expression as well, and leading to cell proliferation and tumorigenesis. And finally, the NF-kappa beta pathway. This is important for innate immune and inflammatory responses, and the activation part of the normal innate immune response. It can also be used by the viral infected cells for propagation and continuing to survive within the host body. So let's kind of transition and talk a little bit about some of the specific types of viruses and some of the diseases that they cause and the testing that we have available for us. And so I wanted to start here with EBV, as it was actually the first virus to be identified as an oncogenic virus. And actually last year in 2024 was the 60th anniversary of the discovery of EBV, or Epstein-Barr virus. And some of the story goes back to Dr. Dennis Burkitt, and you might be familiar with that name, I suspect. And Dr. Burkitt was part of the Royal Army Medical Corps in England during World War II. And he spent some time in Kenya during his time in the war. And after the war, he decided that he wanted to continue medical service in the developing world, and he moved to Uganda and ultimately settled in Kampala. And that is the location where the EBV, or Burkitt's lymphoma, was really recognized. The EBV virus is named after Epstein and Barr, who discovered the virus together with Ann Chong, and they really came to discover the virus after they heard Dr. Burkitt give a presentation in 1961 on the commonest children's cancer in tropical Asia, a hereto under-recognized syndrome. And following that talk, it really kind of inspired further investigation of the Burkitt lymphoma. And ultimately, a research sample was sent back to Middlesex Hospital to be cultured from a Burkitt lymphoma patient. And the virus particles were ultimately identified and further described. And so that's part of the story about the discovery of Burkitt's lymphoma and EBV, and that association and the history that's involved with it. So the EBV virus itself is part of the family of the human herpes virus. It's a large enveloped linear double-stranded DNA virus. It's one of the non-integrative ones and actually persists as a nuclear extrachromal episome. And unfortunately, to date, no vaccines have been found to be effective in preventing EBV. It's really quite ubiquitous, and many people have been affected by EBV and don't even realize it. But occasionally it does lead to symptomatology, and then often, well, not often, occasionally it can also be associated with cancer subsequently in various patients. So here is a description of a couple of the types of EBV-related cancers. So Burkitt lymphoma, we'll talk a little bit more about that. Hodgkin's lymphoma, diffuse large B cell, the post-transplant lymphoproliferative disorders, nasopharyngeal carcinoma, and also gastric carcinomas. So the mechanism of infection and tumorigenesis for EBV is it really, really likes B cells and epithelial cells. So the change in cell type tropism suggests that EBV kind of shuttles back and forth between B lymphocytes and epithelial cells during its infection cycle. And the overall cycle is thought to be starting with an infection of the B lymphocytes. There can be a lymphoblastoid proliferation, which results in the clinical symptomology of mono, and lifelong infection persists in the memory B cells. And you may be familiar already with this concept of latent EBV, and during different types of the latency, it expresses different genes in 3 patterns. Thus, we have latency 3, 2, and 1 or 0. And at each particular point, we have different differentiation of the particular cells, as well as different expressions of the viral proteins and associated diseases that we can see at various latency phases. And so this is important to really kind of understand that not at every latency are the same proteins or genes going to be expressed. And so this helps us kind of derive what is the best testing methodology to most effectively identify an EBV infection. So for instance, EBRs are almost always expressed, whereas the LMPs are not. So back to Dennis Burkitt, what he noticed in Uganda, where he was seeing a really quite frequent recurring incidents of children quite young coming into the clinic with swollen faces, swollenness in the jaw. And ultimately, this has been classified as Burkitt lymphoma with this very characteristic pattern that we see with the starry sky pattern, the tangible body macrophages as such. And this is a couple of pictures of the Uganda Cancer Institute that still exist, where Burkitt originally identified and described this etiology or this disease course. And it's Uganda Cancer Institute was a place that I happened to have the opportunity to go visit in 2013. And these are a couple of pictures of what the Cancer Institute still looks like. And it's a collection of several buildings with the hospital and surgical facilities to service patients in Uganda. And it still persists to this day. As we know for Burkitt's lymphoma, in terms of molecular characteristics, we're often looking for the 814 translocation. And we do have really what's thought to be 3 different descriptions or subtypes of Burkitt's lymphoma. The endemic are the ones that were particularly identified in the children of Uganda. About 90% of these are EBV associated with a young age at diagnosis, typically the extranodal sites such as the jaw. And it's really thought that malaria plays a role in the development of EBV, such that chronic malaria infection might lead to immune suppression and giving EBV an opportunity to kind of flourish in the particular patient and develop into a cancer. We also have sporadic and HIV-associated types of Burkitt's lymphoma, which I'm not going to go into in more detail here. When we think about epithelial cell infection of EBV and associated cancers, nasopharyngeal carcinoma probably comes to mind most readily. So for nasopharyngeal carcinomas, about 99% of them are the non-keratinizing type or the lymphoepithelial type. And we do see a bimodal age distribution in patients who have nasopharyngeal carcinoma. We can see that in various ethnic groups, and there do seem to be some environmental factors as well as some genetic factors, such as this particular HLA type associated with the development of nasopharyngeal carcinomas. So just a few pictures of the classic lymphoepithelial undifferentiated type. We can see an abundance of inflammatory cells kind of intermixing and partially obscuring these larger epithelial cells, which are keratin positive if you throw cytokeratin on them. In terms of testing for EBV, it's really focused mostly on in situ hybridization or the EBER-ish. It's thought that PCR is likely too sensitive. Many people have been exposed to EBV at some point in their life, and so there's probably quiescent EBV or latent EBV in a number of cells, and so PCR might be picking up something that's not quite significant. And so in situ hybridization allows us to actually visualize the ISH probes within the tumor tissue itself. There's also a couple of IHCs we can utilize, but this is highly variable, as we just talked about, depending on the type of latency that the tissue is in. So EBV-ish or EBER-ish is a really nice stain showing you this dark nuclear staining in the tumor cells, indicating the presence of the RNA virus within the tumor tissue itself. And just an example of the LMP. All right, so let's transition to HPV. There's a lot to talk about with HPV. As many of you probably are familiar, we do have this history of cytopathology developing in associated with cervical cytology by Dr. Papanicolaou, who did the majority of his work around the 1920s through 40s. And the story of HPV connection to viral or pathogenesis was in part due to the work of Harold Zurhausen. And Dr. Zurhausen was a virologist who contributed a lot to this field of oncogenic virology. And he initially was looking at cervical cancer, studying HSV in association with cervical cancer. But indeed, he found that not all tumor samples contained HSV DNA, which led to the question of whether or not that was really the causative agent. And then he started to link together some medical reports of patients that had genital warts as well as cervical cancer. And he kind of did some more work in this area and ultimately developed the theory that HPV was the causal agent for cervical cancer. And he published on that result in 1976. And then he spent the next decade or so into the mid-80s doing more research to identify first HPV in genital wart samples. So he identified HPV 6 and 11, and then ultimately discovered the high-risk genotypes HPV 16 and 18 in cervical cancer samples. And he is credited, at least in the source that I read, that in 1986, he is credited with actually reaching out to the pharmaceutical companies to help encourage them to develop an HPV vaccine. And so from there, kind of the rest is history. And I think it's really kind of fascinating to hear some of the background of how these stories unfolded. And unfortunately, Dr. Papanicolaou died in the early 60s and was not alive at the time with the discovery of HPV being causative in cervical cancer. So I wish he had known the end of that story. I'm sure he would have liked to see that all tied together and his work being so important for preventative care. So HPV itself is a small non-enveloped double-stranded DNA virus. There are more than 180 genotypes that have been described, and they do have this particular tropism for mucosal and cutaneous squamous surfaces. The low-risk HPV associations include warts on different surfaces. HPV 6 and 11 are the most common, and nearly all recurrent respiratory papillomas are also associated with low-risk HPVs. The high-risk HPVs, of course, we know them as causative for cervical cancer, which is the second most common cancer in women. And most commonly, we see HPV 16 and 18 being primary genotypes. 18 is a little bit more associated with the endocervical adenocarcinomas, just as a note. And of course, the precursor lesions, which is why we do cytology as well as cervical biopsies to identify any precursor lesions. In addition, we know that about 50% of oropharyngeal squamous cell carcinomas are associated with HPV, and the vast majority of these are due to HPV genotype 16. And the story of HPV, I think, is kind of incomplete without talking about the story of Henrietta Lacks. I highly recommend you read this book if you haven't. Henrietta Lacks is a woman who in the early 50s developed cervical cancer and was seen at a Baltimore hospital. I'm not going to name names, but you probably know if you know the story. And she died pretty quickly from her disease, but during biopsies, tissue was taken, which later these cells from the tumor survive very, very well in the lab and have gone on to become the HeLa cells, which you probably have heard of and are familiar with, have been really, really valuable in the study and the research of cancers. And there are, tens of thousands of publications that have utilized HeLa cells. But the main issue that this book and Henrietta Lacks' story raises is that at the time that she was being treated, there really was no requirement for informed consent for patients. And also, there was a lot of still racial and class discrepancies and in access to care and how patients were treated. And so this book really does a beautiful job of discussing some of the ethical issues of race and class in medical research and, what was acceptable at that time, and how her family, really did not know and never gave consent for her tissue to be utilized in the way it has been. And in addition, this book also talks to a lot of her family members and kind of gets that whole full story of what happened to her family and her children. And out of kind of a lot of this work around her story, there was establishment of the common rule in 1991, which says that informed consent is absolutely necessary, and doctors really do need to get informed consent in order to do research on patients. And so that's why we have IRB and all those regulatory mechanisms now. And kind of the end of the book, we do see a little bit of kind of closure for the family, which I think is a really nice story to kind of understand, but it's a really disturbing story as well. So I do recommend you read it because it does talk about a lot of the issues that I think we really need to be cognizant of the history of medicine, as well as having respect and utilizing the patient samples that we do have access to now and going forward too. So let me move on from my little soapbox on that one. And so talking a little bit more about HPV-related neoplasia, we do have some changes coming our way in terms, or that have already been established in terms of cervical cancer screening guidelines. It's my understanding that there's still a little bit of ambiguity as to how this will all flesh out, because I think we have some guidelines that are released, and we have another group that is still working on finalizing guidelines. But I think one thing to take home from this is that there is more of a movement towards primary HPV testing for patients at about every 5 years, so 5-year intervals. And so primary HPV testing, as opposed to co-testing or PAP only, will kind of shift the paradigm of how we approach HPV testing as well as cytology. And so far, although at least the ACS guidelines were released in 2020, the uptake of primary HPV has been really quite slow, at least in the US. And there are some challenges and limitations with getting that all set up and accepted, I think, by both patients as well as primary providers. But to move on from the cervical cancer story, let's talk a little bit about the oropharyngeal squamous cell carcinomas. We are definitely noticing that there seems to be an increase in the past couple of decades of the incidence of oropharyngeal squamous cell carcinomas. And these represent about 25 to 30% of all head and neck squamous cell carcinomas. And these arise from the crypt epithelium of the tonsils, so the palatine tonsils, the lingual tonsils, the base of the tongue is where we see these tumors localizing. And they're really important to identify because they, well, one, they have a little bit of a different morphology, but they also have a little bit of a different biology. We typically see the HPV positive ones in patients who are younger, never non-smokers, and they are affected by usually an overall better prognosis, but not necessarily. So 3-year survival follow-up rates from a publication that's over a decade old now showed that they had a better prognosis overall with greater than, or survival rates up to about 80%. So these are a little bit of a different type of tumor than our standard tumor. So as you are familiar with, these are typically kind of this non-keratinizing type look to them. And we can see that there are a few different types of subtypes that we can also see too. And in the most recent WHO, we do see that this change in classification of the oropharyngeal cancers to really kind of create their own category for them, and recognizing that they are biologically a different or a unique type of tumor. And so now we also have this implemented in 2018, the difference in staging from HPV-driven P16 positive oropharyngeals versus the HPV negative. And this, for your reference, we have differences in how we stage them in terms of our T and our N and our overall staging category. So this is in the presentation if you want to look at that a little bit more carefully. So in terms of the mechanisms of infection and tumorigenesis, they, again, like many others, lead to cell cycle dysregulation and live particularly in the epithelium. And so the viral genome is important to be a little bit familiar with. We do have early genes, and then we have latent genes or later genes, which encode for the capsid proteins. But the E6 and E7 oncogenes are really the ones that are really important for viral integration and viral effect. And so the E6 plays a role in binding to P53, which leads to degradation of P53 and also leads to the lack of cell cycle progression or cell cycle arrest. And so there is a lack of apoptosis overall is the manifestation of this inactivation. And then the RB pathway is altered by the E7 oncoprotein, which leads to constitutive activation of this particular pathway. And I'm sorry, my typing is a little bit off here with the transition to these slides. But essentially what happens with the constitutive activation, P16 proteins are trying to put a block on this activation. So they are trying to offer an inhibitory effect to break this cycle, which means that leads to increased P16 expression. So you have a hyper or large amount of P16 expression because it's trying so hard to shut down the cycle without success. So this is kind of the overall mechanism by which we see that increase in P16 expression. And the HPV kind of behavior or biology is really interesting in that the virus typically infects at the basal layer, usually in the context of microtrauma, so that there is a little bit of damage, which allows the infection to get into the cells. And then it continues to ultimately persist and reproduce within the cells. Ultimately, if it becomes integrated, it can lead to the dysplastic features that we commonly see associated with preneoplastic lesions. The HPV virus is also really, really good at evading the immune system. It's really exclusively an intraepithelial infection, so there's no blood-borne or viremic phase of the life cycle. It's just within the cells and is practically invisible to host defenses. So there's really no virus-induced cell death, very minimal, if any, inflammation or release of pro-inflammatory cytokines. And so it really does a good job of evading kind of our scoping immune system that is trying to identify any pathogens. In terms of immune evasion, we also see that the oncoproteins can play a role in this, so that, for instance, the E6 protein inhibits epithelial dendritic cell interactions. And although the vast majority of infections do resolve via cell-mediated response, we do have persistent disease in a proportion of patients. HPV is one that we do have vaccines for. Just to note, the Gardasil 9 is approved in 2014 and also approved for patients up to age 45. FYI, if you are younger than that, you can still get the vaccine. So testing for HPV, you're probably familiar with using P16 immunohistochemistry in this context. And just to make the point that P16 immunohistochemistry can be very useful, but it really has to be context-based. So in the cervix, in the oropharynx, for instance, where we see these HPV-associated neoplasms, P16 can be used nicely as a surrogate marker. However, if you are not in those locations, we can see disruption of, the P53 and RB pathway by different mechanisms besides just HPV. And so P16 immunohistochemistry is not ubiquitously defined as being associated with HPV, obviously. And so it has to be context-driven. We do have PCR-based assays that we can utilize too, as well as some in situ hybridization or ISH assays. So last year, I believe this came out, the human HPV testing updates in head and neck cancers. So these are just a couple of the highlights, but if you would like to read the manuscript, it contains 16 recommendation statements overall. But the highlights I want you to take home are that it's recommended that there's testing on all new diagnosis of oropharyngeal SCC. And in this context, the testing by surrogate marker P16 is acceptable. It's important to include, this is a new thing that is included, that include testing for sinonasal squamous cell carcinomas. And this approach of testing is a little bit different. It's recommended to use P16 to screen, but it's recommended to perform an RNA-ISH assay to confirm that indeed there is HPV virus in those tumors. Also, for metastatic squamous cell carcinoma of unknown primary in a cervical lymph node, it's important to perform HPV-specific testing or the surrogate marker P16 followed by HPV-specific testing. So P16 alone in an unknown primary with lymph node metastasis is not itself sufficient. They do recommend you add on HPV-specific testing, which could be PCR, which could be ISH. And then I think this is just what I said, HPV-specific testing. You really want to use tests that exhibit optimal performance characteristics. So RNA-ish actually performs much better than DNA-ish. And so RNA-ish or DNA-based PCR assays are really the preferred testing mechanisms for this specific testing. And just to remind us, what is the P16 scoring cutoff? It has to be at least 70% nuclear and cytoplasmic with moderate to strong intensity staining in order to call it positive. Otherwise, it's negative or equivocal. So it's not uncommon to see heterogeneous staining in non-HPV driven tumors. So just keep that in mind. It has to be 70% or more. And then in terms of PCR, different testing methodologies, they can be quantitative or qualitative. They can be genotyping specifically or not. This assay here, this image here on the right is from an assay we used to run in our laboratory, which we use for HPV genotyping from FFPE tissue. This was called a linear array assay, and it had 37 genotypes as part of the assay. And just to show you how you read it, these blue lines indicate down here at the bottom the internal control. And then up here at HPV16, that's where the indication of that viral genotype is highlighted. So sometimes we would see mixed infections. That was really not uncommon to see, but this is one mechanism of genotyping. Currently in our laboratory for FFPE, so mostly for the oral pharyngeal cancers, we're doing a similar genotyping assay by milk curve analysis, which identifies up to about 14 genotypes. And then for cervical specimens, for cytology specimens, there are a couple of FDA-approved assays that are out there. So one that our laboratory uses looks for 14 high-risk HPV types and genotypes, specifically 16 and 18, and then a pool of other high-risk genotypes. So several different approaches to PCR testing. And then in terms of HPV-ish, you can have multiplex assays, which will pool high risk and low risk, or you could have tissue specific or type specific or genotype specific probes that you could utilize as well. And kind of similar to the Eber-ish, you can see in the tumor tissue itself that you do have signal indicating that you do have virus integrated into your tumor cells. And lastly, let's not forget that there is emerging this concept of circulating tumor HPV DNA testing. So it's really performed similar to another liquid biopsy or another ctDNA type of assay, where blood is taken from a patient and plasma is and ctDNA is extracted from plasma. And within that, you can have fragments of the DNA virus, which you can subsequently amplify by either like a digital PCR type assay or NGS. And the idea is that you could track patients over time in terms of how much volume or how much their ctDNA is kind of hovering at. And so right now, this is mostly integrated within clinical trials. It's not included in the NCCN guidelines yet, but we do have some providers who are utilizing these types of assays at our institution to try to monitor patients over time to kind of predict when they might have recurrence of disease. And so that's one possible use case for an assay like this. So let's move along to Merkel cell polyomavirus. So Merkel cell is a small, non-enveloped, double-stranded DNA virus. It's really kind of one of the newer viruses that was described only in 2008. And its mechanism appears that it infects fibroblasts. However, exactly how it leads to oncogenesis is still not known. And the question arose, does Merkel cell have a viral or infectious origin really kind of came about because it was observed that, like Kaposi sarcoma patients, MCC frequently occurred more than expected in immunosuppressed transplant and HIV patients. And so indeed, the Merkel cell virus has been identified as being associated with these particular tumors and oncogenic. So Merkel cell carcinoma, just a beautiful example here. And we do have an IHC stain that we can use for the polyomavirus to indicate that it is present within the tumor cells itself. And just to continue on to HHV8. So it's a large enveloped linear double-stranded DNA virus. So this is, again, the Kaposi sarcoma virus or associated herpes virus, as well as HHV8. We can see several different diseases associated with this: primary effusion lymphoma, multicentric Castleman's disease, of course, Kaposi sarcoma, just an example. And the mechanisms of infection, although are a little bit interesting in that although it seems to be necessary for KS development, it is not sufficient by itself. And it really does seem to have to need a cofactor, and the most commonly we see is HIV. And so it's thought that the mechanism is that there needs to be some other instigator of immunosuppression in order to allow this virus to become pathogenic and drive a tumorogenesis pathway. So it infects endothelial cells as well as the, excuse me, it affects primarily endothelial cells, and it is attracted to areas of inflammation. It does have the capacity to induce this pro-angiogenic molecules and has what's called paracrine oncogenesis. The LANA proteins are ones that we can see that we can test for. These are important to maintaining viral replication. They inhibit p53 and RB, not surprisingly. Those are key pathways that many of these viruses target. So in terms of testing for HHV8, PCR testing is available, but we also do have the LANA immunohistochemistry, which we can identify directly within the tumor tissue itself. And so to start to wrap up this discussion, I just wanted to touch very briefly on the hepatitis viruses. I'm not going to go into too much detail about them. I just wanted to put in a little bit of information about different testing approaches that are available for the viruses. So for instance, HCV, we do think about screening and diagnosis. So there is HCV antibody testing, which is generally thought to be the screening test. And then if that's positive, it should be followed up by a confirmatory or diagnostic test. HBV, on the other hand, has a little bit more of a complex testing strategy, and that there are typically 3 different antibodies and antigens that are tested for. And per below, the combination of these helps us interpret what biologically is happening with a patient. So for instance, in this top part of the table, if all 3 are negative, this patient is not immune. If the surface antibody is positive, it means the patient is immune, meaning they've either been vaccinated or have had a prior infection that they have recovered from. If the antigen, surface antigen, is positive, it means there's acute or chronic infection that is an active process. And then if the core antibody is only positive, it's not quite certain how to interpret that, and additional testing is probably needed, or repeat testing in the future. The hepatitis D virus, there is also antibody testing available for this, as well as RNA testing. And then we do have instances where we are asked to perform viral load testing or surveillance testing, and those are done by a more specific quantitative PCR-based assays, so that you can follow a patient over time, see if they are responding to particular therapy or not, and follow them prospectively. And just for a little bit on HDV. I think it's kind of an interesting virus in that it is dependent on HBV infection. So HBV is a prerequisite for HBV to have any pathogenicity. And so, sorry about the resolution of this image, but I thought it was important to explain the difference between a superinfection and a co-infection. So someone with chronic HBV who becomes infected with hepatitis D, this is a little bit more of the common scenario. And these patients are typically more likely to develop chronic disease, which leads also towards, the chronic disease manifestations, which can be cirrhosis and then ultimately hepatocellular carcinoma. A co-infection is when someone becomes infected with the two viruses simultaneously. This seems to be a little bit less common and a lower risk of developing chronic disease overall. And usually both viruses are able to clear in this situation within, 6 months or so. And so just to kind of wrap up this talk, I hope you've taken from this that there is really a rich history in the identification of oncogenic viruses, which is quite fascinating. And viruses are very clever in utilizing the cellular mechanisms that they take advantage of for their pathogenesis. And there really is no single mechanism by which viruses cause tumors. There's a multifactorial approach in different situations for different viruses. So with that, I want to thank you very much for your time. And I'll stick around a little bit for any questions that might arise. Thank you.
Thank you so much, Dr. Tafe. This was wonderful. And you have covered all the different oncogenic viruses and their mechanisms, associated cancers, and testing methodologies. This was great. And there are quite a few questions from our viewers. Would you mind stop sharing your screen, please?
Sure.
Thank you. So one of our colleague who is listening from Mexico has this question for you. First of all, they thank you for your talk, and which they loved, and says greetings. And the question that is with it is that in your experience performing immunostain for P16 and finding it diffuse and en bloc positivity, but HPV molecular testing when it is negative, so what would be your recommendation in that case? So that's one question. And just a follow-up for the same question, I guess. Is it possible that in poorly differentiated lesions, this pathway could be activated without infection? Thank you.
Yeah, so I think kind of the similar answer to both questions is that remember that there are multiple mechanisms to activate or inactivate the P53 pathway and RB pathway. So both of those are tumor suppressor genes. So you can have mutations that can lead to inactivation of those pathways. So it's not HPV driven alone. So we do see that with P53 mutations, for instance, some of those tumors can have overexpression of P16 that is completely independent of HPV. So one great example of that are ovarian serous carcinomas. We typically think of them P53 muted as well as P16 overexpression. And that mechanism is via the P53 mutation. It's not associated with the HPV. So hopefully that answers your question.
Right, because that's a great, actually this question is very common from anyone. And then you mentioned a reference to ovarian serous carcinomas, so which will often show P16 positive, but there is no way that it is connected to HPV. And you said in the beginning that P16 is a surrogate marker, so it is not HPV specific marker, which can be a misconception.
Correct. Yeah. Yep.
So there is another question. In many low resource settings, HPV or EBV testing is not routinely available. So what are your most practical and cost-effective strategy or surrogate markers that can be used in such environment? Of course, there is P16 that you have mentioned, but do you have any practical advice to our colleagues who might not have access to in situ hybridization or molecular testing? Thank you.
I think if you have a capacity to do immunohistochemistry, you can often do ISH at this point, because I think our similar processors are able to do the ISH studies as well. So that might be one of the most cost-effective mechanisms as well, are the EBER-ISH or the HPV-specific ISH assays that can be done on the histology immunostainers.
So there is a question from one of our viewer who is not a medico. So the question is that if HPV is positive and if there is some abnormal pap smear, so then how often do you do it? So I know there is guideline, but maybe you can throw a little light from your own experience.
Yeah, so I think if HPV, say it again, it's HPV is positive and there's no pap smear.
No, and there is some abnormal pap
Oh, and
test.
there's
So
no
how
abnormal.
often do you do it?
Yeah, so at that point they kind of fall out of the screening pathway and they become followed up diagnostically. So if there's abnormality on the pap, then they would probably go to colposcopy at that particular point, which would lead to a biopsy or at least an ECC, and then follow up from there.
Right. And then also a very simple question, I would just read it for you, that talking about HPV per se, does it disappear on its own or it never disappears once a patient is infected?
Yeah, thank you for that question, because HPV can disappear. So a lot of times, probably about 90%, I think is the estimate, 80 to 90% of people clear the HPV infections. And so it's possible in your life to be positive and then become negative as you have clearance of that. And HPV is different from EBV, which stays within cells as a latent virus kind of for our lives. I think there's a little bit more chance of EBV persisting latently than there is HPV. But so yes, HPV does get cleared or can get cleared, but in a proportion of people, it doesn't get cleared. You can also have multiple infections over your lifetime too.
So is there some ways that can be suggested for patients to help in clearing HPV rather than improving immunity and anything that they can do?
Not to my knowledge that I know to share. Yeah. Yeah.
Because there is a lot of talk about improving immunity and then things to do, how to boost your immunity if you are testing HPV positive, but yeah, just improve your chances that it becomes negative.
Right. Yeah. I think
So that's a very good point about.
based.
Sorry, you were saying something. Go ahead.
No, go ahead.
No, like I mean, some very important point that you mentioned about the latency and its comparison with EBV, right? So there is more chance that EBV is not going to go away because it stays latent and it can get activated at any point.
Right.
Right. So there is another question, Dr. Tafe, is that talking about EBV. So you said in the beginning that we don't have a vaccine yet for EBV. So what are the roadblocks or the hurdles in developing a vaccine for EBV? We have vaccine for other viral related tumors.
Yeah, I don't know what all those are. I know there's been a lot of effort to do it, but nothing's that has been successful yet has come about. And I don't know all those roadblocks. I'm not experienced in the whole virus or vaccine genesis process for EBV and all that history and what has been challenging with that. So I can't completely answer that question. I know people have been working on it and they haven't found one yet that can be utilized.
All right. No, thank you. One question I think you already answered is that would you consider P16 alone a reasonable proxy for HPV in oropharyngeal carcinoma where PCR or in situ hybridization cannot be performed?
Yes, I think in the anatomic context of a HPV or of oral pharynx with the kind of the right morphology and clinical story and P16 positive, that is an accepted test as a surrogate for HPV in that context. Yes.
Right. So I mean, as opposed to cervical cancer, right? Because I mean, if there is a, I mean, like maybe a high grade like ACL, even in anal lesions. If P16 is positive, that doesn't mean that it is HPV related, right? But probably not with oral cancers, right?
Yeah, I think most of us are. I think in cervical cancer or cervical HSIL positivity, I think we are pretty comfortable with that being HPV related. I would say that anatomic site is acceptable in the anal area and perianal area as well. We do think of that being associated with HPV, but it's not true for other anatomic sites where we don't see such a high prevalence of HPV associated lesions.
Great, thank you. Another HPV related question, two or together, is that how effective is HPV vaccine in reducing cervical cancer risk? There is one question. And then if HPV vaccine preventive for both oral and cervical cancer together?
Yeah, so I don't recall what the actual predicted number is for HPV vaccination decreasing, but it does cover, particularly the 9-valent covers up to, I think, pushing 90% of all the causative variants of cervical cancer, and there is some cross reactivity with other genotypes as well. I don't know the exact number, but it's quite high in terms of the expected coverage, and I'm sure someone has that number somewhere. But one of the challenges with vaccination is that it's often a multi-series vaccine, and so not everybody is getting the whole complete series, or they're not getting it at a young enough age as well. The second question, yes, the vaccines are expected to cover both cervical cancer and oral pharyngeal cancers, which is why it's being encouraged that both people of all genders receive the vaccines. And so to be able to prevent both types of cancers or all those related cancers.
I know that's, I think, a very good point from public health point of view, is that there can be a misconception that HPV vaccine is only for young ladies, not for boys, and so because it is important that both genders should be covered with HPV vaccine.
Yeah,
but in
correct.
many countries, I think that HPV vaccine is still not part of a national vaccination program. I, for one, know that in India it is optional. Like, I mean, people have to get it by themselves. So I think that people need to be aware, and maybe like it can be more incorporated into national vaccination programs, right?
Yeah, I think that would be ideal to see more of that, because like the statistics show of the viral associated ones, it's about half of them are HPV associated cancers. So it's a high burden of disease there for sure.
Right. So one question that I saw online is that what are the emerging oncogenic viruses we should keep on our radar in the next decade or so, which can cause the tumor?
That's probably a list beyond everything that I can think of. I know they're looking at CMV, for instance, is one that's being studied in that regard and has not been bumped up to a category 1 yet, but I think they're looking at that. I think we're going to hear more about the COVID story and association with oncology as time progresses as well. So I think those two come to mind most readily right now.
Right, right. That's good to know. I think at least we will know more, like, with time, of course, and how it progresses. But it's always fascinating to keep an eye out for possible viruses. I mean,
Yeah.
it's not that there is, unfortunately, I mean, biology and history tells us that it's not limited, that only 5 or 6 viruses are causing cancers, and there won't be any other viruses in the future, right?
Right.
So yeah.
Yep.
There is one question from a viewer, which is interesting, is that if you had to pick one oncogenic virus that has taught us the most about cancer biology, which one would that be in your mind, and why?
I would choose HPV. I think it's probably one I'm maybe most interested in, so I'm probably biased, but I think that it's such a comprehensive story from being able to recognize precursor lesions, having a mechanism to screen for that, and the development of vaccines that could prevent these diseases. So perhaps it's the nature of the types of cancers that arise associated with HPV that they're a little bit more like the cervical cancers. They're a little bit more readily accessible, so that we do have the capability to develop screening mechanisms for them. And I think HPV is really fascinating too, because the whole oropharyngeal story and just different anatomic sites can be affected. And so I think, yeah, so my answer is HPV. I think it's just totally fascinating, and that we kind of keep seeing this theme of oncogenic viruses coming up at different places in the body.
Thank you. There is a comment from one of our colleagues, and of course, a friend of mine who is a pathologist in UK, Dr. Angela Ralte, who has this comment, actually more probably to one of the previous questions I saw on YouTube, is that in the United Kingdom, HPV positive but cytology negative patients, they do get repeat screening test in 12 months. I think it is the same here as well, right?
HPV positive, cytology negative. Yeah, I think so.
Yeah, so because they are definitely at high risk, so they need to be screened for.
Yeah.
But as you said that, there is a chance that they will clear the virus. And there is nothing to worry about. That if there is HPV positive, but without positive cytology, so that is a good news for the patient anyway.
Right.
So yeah, no, I think. Here is one more question I saw for you. So do you foresee any therapeutic exploitation of the viral pathways, such as targeting viral oncoproteins or immune checkpoints?
That's a good question.
Anything
yeah, I guess probably. I think, let's see. I think there are some examples of that in some of the viruses, like probably HIV, HCV, the drugs that have been developed to try to treat those viruses are targeting very specific kind of viral associated mechanisms that help the viruses get into cells and become infectious. So I think we're seeing that in some kind of situations, but perhaps not everything. But we have, the concept of targeted therapeutics for somatic mutations in cancers. It seems possible that maybe we have people studying how to exploit the viral oncogenes in order to do kind of a similar process.
Right. Thank you. One last question. I don't understand the question much, but still I will read it to you. That's on YouTube. That what is to be mentioned in a pap smear report at the end? So probably it is connected to the HPV testing. I'm not really sure exactly what it. If I'm able to understand the question exactly.
Yeah, I'm not sure exactly what they're asking. I'm sorry.
Yeah, no, sorry. Maybe like you have to whoever is asking the question, maybe you have to follow the guideline if you're talking about cytology reporting, right? So maybe you have to follow the guideline about how to report cytology in the pap smear. And if you are talking about HPV testing, so maybe like, you have to mention that which HPV subtype is positive or not, and if you want to recommend the HPV test. I hope that is helpful.
Yeah, perhaps that's the direction they're headed. I know, like, how it works for us is that we do co-reporting of the cytology and the HPV testing if they're both done, so that they go together into an integrated report, so that the cytology and the HPV are reported together.
Right. Thank you. I think these are all the questions that we got online from our viewers. And thank you once again, Dr. Tafe, for this excellent talk on a very important topic and covering so many oncogenic viruses. And again, a topic that is close to your heart as well. And we really appreciate it. And for our viewers and who joined from many different countries, as you have seen, people joined from Mexico, India, UK, Oman, Brazil, and a lot of other places as well. Thanks to our viewers. And if you like our lectures, so please don't forget to follow Patcast on different social media platforms. And we are also on Instagram, and feel free to follow us on Instagram as well. And we will continue with our lecture series, and hopefully we will have Dr. Tafe again in the future and covering some other topics that interests us and interest her. And as many of you know, that she is a renowned molecular pathologist, and she is also the past president of American Molecular Pathology Society, or AMP, Association of Molecular Pathology here. So hopefully we will get to see her again. And our next lecture is actually on Dartmouth pathology, and we will have the second part of the talk on neck cell tumors, and that is next week on October 28th, and we will have Dr. Hadaskapsky, who will be back for the second part. Thank you again, Dr. Tafe, for this excellent talk.
Thank
Till
you.
next time.
Thank you for the invitation. Thank you, everybody who joined. Really appreciate you taking the time.
Thank you.